Okay, so then okay, good morning, everyone. And thanks for joining us for today's QI Power Hour. This is Caroline Beck with the Saskatchewan Health Quality Council. For those of you joining us for the first time, QI Power Hour is a free monthly webinar learning series hosted by the Health Quality Council here in Saskatchewan. We bring together improvers from a variety of sectors with an interest in improving health and to learn about quality improvement related topics. All of our sessions are recorded and available on the HQC website following the event. Please feel free to share these recordings with colleagues who are unable to join us today, and feel free to check out some past recordings that you may have missed. While you're on our HQC website, we also invite you to sign up for our distribution list to ensure that you receive regular updates to all of our upcoming QI Power Hour sessions. Over the last year, we've been excited to see the continued growth of QI Power Hour throughout our home province here in Saskatchewan, as well as within Canada and even abroad. So thanks for spending an hour of your time with us here today and for your commitment to ongoing learning to improve the systems that you are each a part of. We're looking forward to your engagement and participation on the webinar today, and we encourage folks to share their questions and insights during today's session by making use of the chat function. So you can access the chat function by clicking on the message bubble towards the bottom of your screen, and this will launch the chat panel on the right of your screen. We encourage you to share your questions, your comments, and your ideas throughout the presentation, and we'll have some time dedicated to questions and answers at the end of today's presentation. Please make sure you send your questions to all participants so that we can all join in the discussion. And just a quick note that you may also see a Q&A tab on the side of your screen. Try to use the chat function instead, just so that everyone can see the questions coming in. So before we get into our session, let's just take a quick moment to practice this function, typing in the name of the organization that you're joining us from today. So we've got a couple people on the line from the, oops, sorry, forgot to put this up on the slide. I got some folks from the Saskatchewan Health Authority, 3S Health, Alberta Health Services. I got some folks from around the province, Moose Jaw. Perfect. Okay, thanks so much for joining us. We're so excited to have you all here today with us. Okay, and we also invite you to tweet about your insights and reflections during our session today. You can use the hashtag QI Power Hour as well as the handles that you see on your screen. Chelsea is also going to pop those handles into the chat for you so that you can reference back to them throughout today's session. Okay, so with that, let's dive into our session for today. I'm delighted to welcome our three presenters for today's session. First, Dr. Jennifer Mervyn works as a consultant on mental health and adverse childhood experiences, doing teaching, training, and currently consults for a working group developing the ACE's guideline for physicians in BC. She was recently acknowledged by the Centre for Addiction and Mental Health as one of 150 Canadians making a difference in mental health. For the last 3 years, Jennifer served as the Practice Initiative Lead for the Child and Youth Mental Health and Substance Use Collaborative for the Fraser region, working for Doctors of BC. Jennifer is Métis and a strong advocate for the Indigenous community. She holds a PhD from the Department of Counseling Psychology at the University of British Columbia, teaches part-time at Trinity Western University, and has a private practice in White Rock. Next, we have Christina Saudi, who is an improvement advisor and an independent consultant who has supported multiple projects in the primary, community, and long-term care realms. Her work has included the design and implementation of BTS collaboratives in areas such as chronic disease management, access, and child and youth mental health. From 2014 to 2017, Christina was the Provincial Collaborative Coach for the British Columbia Child and Youth Mental Health and Substance Collaborative. Christina holds a master's degree in community health and epidemiology from the University of Saskatchewan and lives with her family in Toronto. Third, we have Nikita Soros. Nikita has been with the Doctors of BC for over 5 years, working on provincial initiatives that bring together government and physicians and care providers. She worked on the province-wide Child and Youth Mental Health and Substance Use Collaborative for several years and is now working to support the implementation of primary care networks across BC. She has a Master's of Public Health from Simon Fraser University, lives in Vancouver, and in her spare time loves to travel. Welcome to you all, and thanks for joining us for today's QI Power Hour session. I'll pass it over to you.
Thanks very much, Caroline. And thank you all for joining us today. We're really, it's our pleasure to be able to share with you a little bit about what we accomplished in British Columbia from 2013 to 2017. And as you might all sort of be able to identify with, the three of us are quite passionate about this work. I think it's probably a shining light for us and for all of us over the last couple of years. So we've tried very, very hard to keep our comments to allow for a little bit of time for discussion at the end, and we will try to keep on track. And we sort of focused our comments on those things that are most transferable or we thought would be most interesting to folks that are on the line. And if there's other things you'd like to know, please feel free to chat them in, and we'll see how we can answer your questions at the end of the presentation. So, there we go. Okay. So the initiative that we are going to be sharing with you today is the Child and Youth Mental Health and Substance Use Collaborative, or the CYMHSU Collaborative, or just the Child and Youth Collaborative for short. It ran from 2013 to 2017 in British Columbia, and when it closed, it was the largest improvement initiative in the province to date. And as I said in our comments today, we're going to try and focus mainly on those things that are transferable to others that want to do similar work, but can certainly dive into different aspects that might interest you. But before I get into some of the specifics around the model, I'm going to pass it over to Nikita, who's going to talk a little bit about the sponsoring organizations and where this work came out of.
Thanks, Christina. So very quickly, a quick overview. We are quite lucky in BC that we have a really strong relationship between the Doctors of BC, formerly known as the BC Medical Association, and the BC Ministry of Health through this agreement called the Physician Master Agreement. And we have four committees, as you can see here, who focus on the GPSC focuses on the needs of full-service family practice. Shared care focuses on where GPs and specialists can come together. Specialist Services Committee focuses on specialists, and the Joint Standing Committee focuses on rural issues. So we were quite fortunate that for the Child and Youth Collaborative, 3 out of these 4 committees came together to support. So we were really looking at how GPs and specialists can come together to support youth and families, working with government. And on the next slide, you'll see that from the beginning, we were very, very fortunate to have very strong government commitment to this work and a really strong relationship between physicians, government, other care providers, and youth and families. So this initiative came out of our Ministry of Children and Family Development and was brought forward by them, knowing that there is a need to improve child and youth mental health and substance use in the province, along with a very strong commitment from the Ministry of Health and Ministry of Education. And as Christina and Jennifer talk more, you'll see different places where these 3 ministries played really important roles. Back to you, Christina.
Thanks, Nikita. So one of the things that I think everyone involved in the initiative is most proud of is by the reach that we had by the time we ended in December of 2017. We had over 2,600 participants, and you can see the makeup there on the slide, and that represented 64 communities across BC, which really span the majority of the geography of the province. And I think most notable is that we had over or almost 300 youth and parents that were involved. And I'll talk a little bit more about the youth and parent involvement in a few minutes. But I think one thing to note about that number is that is the representation, or all of these folks is a representation of those people that we had sort of officially noted on as working group members and as team members. But there is sort of a network of individuals that would have been also involved that may not have been official written down members. So the reach of the collaborative is likely even larger than that which is represented on this slide. But like any great initiative, it all comes out of somewhere. And I think the story of the collaborative and where it started is similar to where some other initiatives start, which is that when the collaborative started in 2013, there was a collective recognition that the experience of youth and families in trying to access supports through the mental health and substance use services in our province was not where it should be. And this was something that was verbalized over and over again by youth and their parents, and was also felt by the different care providers involved in those services, from GPs, specialists, clinicians with MCFD, educators, and service providers and family. And so, at a seminal meeting that happened in the spring of 2013, these groups came together around a patient journey map. Some of you might have been know what that is. Sort of a depiction of a experience of a young person and their family and trying to access services and how they fell through the gaps and what that meant for their family. And at that time, it was recognized that based on the gaps that we were trying to address, there was no way that any one organization could do this on their own. And there needed to be a coming together of all these organizations in a coordinated way to address the issues together. And so at that meeting, there was decided that we would move forward with the Breakthrough Series Collaborative. And we were very lucky to have sort of trusted, inspirational leadership to be able to move that forward. And then, of course, a strong signal of funding from originally the Shared Care Committee at Doctors of BC and Ministry of Health. And I think it's important to note that originally we started with the eight divisions of family practice and 8 communities in the interior of BC before we moved to the other 4 geographic health regions across the province. So, this is supposed to be animated, but that's okay. So some of you might be familiar with a model of Breakthrough Series Collaboratives through the Institute for Healthcare Improvement. And one of the things, I think a couple things that are notable about them is that they provide sort of a concrete learning structure that you're able to draw from to help people moving forward to share and improve over time. And so we drew from this learning structure to look at providing in-person learning sessions with action periods that went in between as a way to keep people connected, sharing information around what everyone's doing, and sort of providing them with new ideas moving forward, and then having sort of support for action in between. So we had learning sessions that happen every 6 months after the first year, and the learning sessions that happen in between. But then in between those in-person learning sessions, what we had was monthly telephone communication with at a regional level, as well as bi-monthly reporting, and then, copious amounts of other communication with their regional support people in the background. And I think something that's really important to note about the Breakthrough Series Collaborative model that was the strength for this initiative was the focus on communication, not just face-to-face, but also sort of email, like we always do, and telephone, as well as the focus that Breakthrough Series puts on sharing. There's a term in Breakthrough Series of all teach, all learn, and that was definitely something that was brought out throughout the collaborative, that every community has something to learn from another, and every community has something to provide to others in terms of ideas moving forward. And then, of course, the model itself provided milestones that we were able to work towards with teams for sharing their work, but also in asking them, when we had groups that were with us for a number of years, that we had them reevaluating their work and making sure that what they wanted to do was reflected in sort of where they were going. And important to note, when we talk about having 64 teams, we chose in the collaborative not to do a cohort model. So we did a sort of a rolling engagement of groups. We started with 8, ended with the 64. Some of our original 8 were with us at the 4-year mark, right until the end. And some of our teams were with us for the last 18 months. We had a cutoff about 18 months before the end, recognizing that was as much, people needed at least that amount of time to get a good footing so they could sustain their work in moving forward. Now, that being said, in 2015, I think we recognized that the work that was happening as part of the collaborative didn't fit all the aspects of a Breakthrough Series Collaborative, and started drawing on some of the literature and methodologies of collective impact. And I have a slide here that compares, so I'm not going to go through it because it's really busy, but I think something to note about the two models. First is that they actually have a lot of overlap. Breakthrough Series Collaboratives and Collective Impact have a lot of overlap with each other in terms of the core components that are required. But there's some very important differences. With a Breakthrough Series Collaborative, you are supposed to have a change package that folks sort of draw from with their changes. In Collective Impact, the focus is more on emergence and of ideas from the teams. And what we realized very sort of early on in the collaborative is we weren't able to provide people with a change package of, here, try these 5 things and you're most likely to be successful. We were asking for teams to tell us what changes made most sense to them. And so that focus on emergence and collective impact became a really important way for us to focus once we realized that it matched better the model we were taking. The other thing is that within collective impact, there's a recognition of the time for building relationships. And because we were working with teams that were multidisciplinary and coming from groups that may have not worked together before, or if they had, that relationship might have been strained, there was a large build-up time within communities in building those relationships. For some of our communities, the first year was really about building relationships and coming to an agreement on how they were going to work together. But another thing that we drew up from BTS, which was really important, was the use of improvement methods, and that's something that is inherent in that model and not as much in collective impact. And so we made sure we brought that with us as we move forward. And then, of course, the learning structure in a BCS was one that we stayed true to right to the end. This was the structure of the Child and Youth Collaborative. And a couple things to note here. The first is that children, youth, and parents with lived experience were really at the center of everything we did. And by the time we closed the collaborative, youth and parents with lived experience were members of almost every single working group and local action team in the province. And I'll talk a little bit about that in just a minute. You'll also see the list of the 64 local action teams that we had there. And for those of you that know BC geography, it does span the bulk of the province. And then, of course, the steering committee and the mental health and substance use faculty that had their own bodies of work. And so, gotta use this. Wrong one. Something important to note about the relationship between the local action teams and the working groups. So the local action teams were multidisciplinary groups on the ground. And the working groups under the clinical faculty and the steering committee were system-level working groups that focused on issues that were bigger than any one community could address. So as issues came up from a community level or from any of our partners across the province, and it was recognized that this was something that was really beyond the scope of any one community, it was elevated up to be a working group through either the mental health or substance use faculty or the steering committee. And in that way, the folks that had a provincial mandate were able to address issues that were cross-cutting across a number of different jurisdictions, but have the local action teams on the ground to inform their work and test out these ideas in real time so that we could learn as we move forward in terms of what was going to work best for each other. And one example of that is the emergency department protocol. This is one of our most successful working groups within the province. And what this came out of was a recognition that when children and their families showed up in crisis in an emergency department, those emergency departments were not necessarily adequately equipped to be able to support them in the best possible way. So with the support of emergency room physicians, folks who worked at the provincial level, as well as folks who worked in community, they were able to come up with a guideline as well as supporting resources to help emergency rooms across the province to better support families in crisis. And once they had a model that was designed for this, they were able to test that with communities that were actively engaged as part of the province, as part of the collaborative, and then look at how to be able to test and roll that out across the province. And a cool thing about this initiative is that it took on a little bit of a life of its own because it is large in its own right. And the work as part of the emergency department protocol continued after the close of the collaborative in 2017 and has now spread to every geographic health region in BC. But at the heart of our initiative and what we really want to be able to share with you today is the local action teams and their involvement in the community-based change. So local action teams was the term that we used for our community teams. And they were truly interdisciplinary groups of individuals at a community level that represented any group that was involved in mental health and substance use care. How were these groups created? They were created by members of the community identifying who needs to be involved. We, of course, would have here's an example of the people who you might want to invite, but the communities themselves identified who needed to be involved and who were critical members of those groups with support from their regional coaches or leads. And so what you'll see there is a typical representation of who would be in those groups. But of course, a group in Vancouver is going to look different than a group in Valemount. And so who made up these groups and the size of them could be anywhere from 7 or 8 people to 50 people if you were in a large urban center. And in that way, they were able to really represent those folks who were able to make a difference in their local community and the resources they had available to them. The local action teams, as well as the steering committee and faculty working groups, all had objectives that were outlined within the charter that we asked them to work towards. And so the work of the local action teams was self-determined. They were able to choose activities that were important to them that they wanted to work on. And all we asked of them was that they identify those pieces that align with the 8 key objectives that were found in the charter. Now, if you have a chance to look through these objectives, you'll note right away that they are very broad. So I would say, aside from maybe a few examples we were able, almost everything that teams wanted to do fit within these 8 objectives. So they weren't binding by any means. And of course, they had support, regional support people that were helping guide them and making sure that they were able to focus on things that were going to matter most for them. When teams started, we asked them to focus on at least one of these 8 objectives. And then as they became more mature, after, let's say, their first 6 months to a year, we encouraged them to look at activities that focus on 2 or more of the collaborative objectives. Something important that I want to mention about the community teams that I haven't mentioned yet. So the signal to be a community local action team could come from any organization. In the beginning, it most often came from a division of family practice, especially in the interior, because we had that structure that we started with. But as we moved to areas where there wasn't as much coverage from divisions, such as the North, that signal to be a LAT could come from MCFD, it could come from education, it could come from a community group. And they sort of, once we had a signal that folks wanted to be involved, we would go and engage with a community and provide an orientation. And because of the way that it started out and the fact that they were meant to be multidisciplinary collaborative groups, right from the beginning it was sort of communities were supported to not have any one group own the work of the collaborative. So even though there might be someone who is a fund holder or a group that sort of initially called the group together, or of course everyone has their disciplines they represent and one group or another might be playing the role as co-chair, it was seen that every group that was part of those local action teams had to be able to support the direction, and no group had an ability to sort of veto or make sort of the final decisions that weren't representative of what folks wanted overall. And of course, that's a fine dance. It's not always perfect. You have to help people to do that in the best possible way. But I think in supporting folks to make sure that the direction they took was truly a collaborative decision amongst those different groups, it ensured that everyone could be engaged and felt like they owned that work at the community level. So why did communities join? One, they were self-selected. So as I indicated, they reached out to us as we grew and said they wanted to be involved. And at any stage in the process, if they wanted to pull out, they could. After we went up there and gave them an orientation, if they decided it's not something they wanted to do, they could. Nobody did. Everyone followed through once they heard about the initiative, but it was always a voluntary effort as opposed to something that you've been conscripted to. And I think the reason why folks decided to join is because there were long-standing concerns at a community level around how they were able to support members of their community and wanting to do that in a different way. They also, as I said, had autonomy to identify things that matter to them. So instead of us saying, we think we know, but what's going to work best from you, we would provide people with ideas. Here's what others have done. But of course, it's up to the community to identify what works best. And by taking that stance, we actually learned a ton about what works in different communities, as way more than we would have had we come with sort of a set of specific change ideas that we wanted people to implement. Of course, they had funding from the collaborative committees, and you can't understate the importance of having that funding. But I think one of the things that's important to note about that funding is that a large part of it went to fund a local project lead that lived and worked within their community, usually about 2 days a week, so like a 0.4 of an FTE. And so that funding supported that individual, and that individual was really the glue to be able to move things forward. They brought the meetings together, they did the reporting, they helped people attend the sessions. So those project leads, they facilitated the meetings, they communicated with their regional folks. They were really key in moving forward. And I think one way to recognize how important they were to these communities is that when the collaborative ended in 2017, a number of our communities sought additional funding from other groups to keep those project leads in place because they wanted to be able to continue the work and they knew how pivotal that role was. And then, of course, when we went to communities, one thing that we heard over and over again was that they recognized the power of working together, in that they saw an opportunity with sort of the province was listening, people who had provincial roles, people who had regional roles, and then, of course, the number of communities that were involved provided economies of scale and an elevation of these issues that weren't necessarily available to them before. And, they weren't sure how that was going to be available in the future. So the ability to work together and capitalize on the focus that we had as part of the collaborative was seen as a benefit moving forward. Youth and families, as I said, was a really big part of this work. I think we're all really proud of the fact that by the time that we finished the collaborative, we had almost 300 youth and parents with lived experience involved. But we didn't start that way. Like a number of initiatives, long-term initiatives, we started with only 11 mainly parents involved and grew that involvement over time with amazing contributions from organizations like the Fourth and the Institute of Families, and from other community partners that were able to support youth and parents in their involvement. And this support came in the form of supporting teams to be able to recruit and support youth and parents in the best possible way, and making sure that there was a voice for individuals in all the different working groups that we had. For me, I think one of the things that I reflect back on now, 18 months out, is the incredible transformation we saw with a number of the youth that were involved. And you see 3 of them on the screen here. And our youth, all of these youth started as members of a local action team, invited to sort of provide their lived experience to inform the work. And all of them in different ways turned out to be leaders of their local action teams and also led work across the province. And I think it was a really amazing thing to see that by the teams genuinely listening to the feedback and acting on what these youth and the parents with lived experience were saying, it was able to help encourage and enable them to take stronger leadership roles. And I think all of them are still involved in advocacy and support work across the province in different ways. And yeah, it's been a really sort of, I think, a highlight and a heartwarming part of this work. So another thing to note about the collaborative is that there was backbone support. So for those of you that know the collective impact literature and the jargon, backbone support really just means there's a support structure of people that are working in the background to keep things moving forward. With an initiative that has 2,600 people and 64 communities, if you didn't have a strong backbone, there was no way that we would have been able to keep up with the number of things that were happening across the province and making sure that we were able to be responsive to people in the moment, as well as sort of capitalize on all the different ideas that folks were trying. They had, so it was a multi-tiered support network. So we had regional support people, both a QI coach and a lead. And those 2 people were supporting their local action teams, as well as doing all of the communication within that region. And the cool thing about having 2 of them was that there was never a time when a local action team didn't have someone to reach out to. So there was 10, so 2 for every of the 5 geographic regions across the province that were able to support their teams moving forward. And a lot of their role was in communication and information sharing, both within teams within a region, but then also elevating things that they were hearing at the regional level up to folks who were working at the provincial level so that issues could be addressed or that good work could be highlighted. And we did that in a number of different ways, both written and verbal throughout the life of the collaborative. And then we also had a number of sort of provincial level support, such as project management support for the working groups, the working groups under the steering committee and faculty, a project director and a provincial QI support, and then project coordinator like Nikita, who really made sure that all of us actually got our work done and people got paid. And then invaluable, but I think often not talked about, was the communication support. And that was an in-kind from Doctors of BC. And Lisa really was critical in making sure that we could get our message out, but also because communicating about what's happening was not only important at the provincial level, but at the community level for them to get support as well. She was able to make sure that the communities had support to communicate and get attention to their work in the best possible way. So that communication support, I think, is often forgotten, but it really was a critical piece for us. So, and I'm going to wrap up my piece here because I want to make sure we have time for Jennifer and her examples of what happened in the community. But what was the secret sauce of the collaborative? So when I reflect back on what I think was really important was, one, it was truly community-driven. The communities identified what they wanted to do. They were involved because they wanted to be involved. And we tried to make sure as much as we could all along the way that no one was imposing a path forward on them, that was coming from them with support. In addition, the funding was what Val, our lead, called value-based funding. So this was that every single community across the province got the same amount of money, no matter how big they were. It didn't matter if you were a small community on Haida Gwaii or if you were a large community like Victoria or Vancouver. You got the same amount of money. And the reason for that was because we were all dealing with similar challenges, even though they might be on a different scale, and a recognition that perpetuating this idea that smaller communities get less because less people live there is sort of perpetuating some of the inequities that exist in terms of funding work in mental health and substance use. So by having values-based funding and providing a pot of money that was equal to the smaller communities, it allowed them to have a local lead to be able to fund that, as well as having money left over to fund some of their activities for improvement. Additionally, from the funding, those community embedded leads were critical. Without them, I think everyone would agree, we wouldn't have been able to do what we did. And the fact that they lived in and came from the home community they're representing was critical. And then, of course, our youth and parent involvement really helped keep us grounded and make sure that we were working on the things that were most important in our province, because it reflected the experience of those that were actually receiving services. But like anything, we did have room for improvement, and I think we struggled to get consistent system-level measurement for the collaborative, things like, percentage of ER visits and readmission rates and all that sort of stuff, not without trying, but we weren't able to get a strong measurement framework. And so that's something that if we were to go back and do it all again, I think we would try to look at how we could do that differently. And then, of course, for me, being part of my job was in the quality improvement aspects of the collaborative. And if I could go back and do it again, I would probably provide more opportunities for people to build QI skill, because we started out with some of that and it got a little bit harder as we got a little bit larger. But that was something that I might be able to look at, be able to do that even better. And I think the last thing that I'm going to say before I pass it on is that really underpinning a lot of the work that we did and the success we had was trust. So there was trust that stemmed through all the different levels of the collaborative, from the trust in communities that they would pick things that made most sense for them, to the trust that the sort of backbone had that the folks that were working at all the different levels were going to be able to provide the support that made most sense to the teams they supported, to the trust that we had within the working groups and those working at the systems level, that they were going to be able to act and move the work forward to the people that needed to know. And without that trust, I think that everyone was working to support the initiative to the best of their abilities. I don't think that we would have been able to move forward in the way that we did and had the success that we did. And with that speedy run through of the structure, I'm going to pass it over to Jennifer, who's going to talk a little bit about what the communities did as part of the collaborative and where the work came to at the end.
Excellent. And are you going to move the slides for me, Christina?
I can, yeah.
Awesome. Thank you. Yeah, so I guess it's been, I think Christina was understating it when she said, it's been a highlight. Really, I think everyone who's been involved in this talked about this as being like the pinnacle or the highlight of our careers, because to be able to have the honor of doing this work and supporting community change in such a huge way where we're seeing meaningful impacts, to me it truly has been like the absolute highlight of my career. And just want to say how much it's meant to each of us, I think, as professionals. I don't know if I can move them, Christina, or if that's you.
You probably can if you put your cursor to the side panel, or I can do it. It's up to you.
Do you want to do it? Can you go to the next one?
Sure. Okay.
All right. So I'm going to run through because I have a various number of different slides here, but I want to talk a little bit about the Langley Lat. You saw Corey in one of the earlier slides, but definitely to see the leadership opportunities that we had for youth arise was amazing. This young man was one of our very first co-chairs. So he actually led a local action team alongside a physician. He was the first youth co-chair in the province, and actually went on after our collaborative to be hired by our local division of family practice into a well-paying position and continues to do youth advocacy to this day. You can see him. He's designed a TED Talk from addict to advocate, where he continues to get a ton of different views. And his reach is really, I think, amazing to see, not only just within our province, but far beyond, and has traveled around Canada, being able to talk about what we need to do to increase access to services. I think it's interesting overall to look at the different ways different communities actually got to accomplish our goals. So the two goals overall in the collaborative were to increase access to mental health and substance use services. But secondly, it was really to make sure that our youth and our families were at the heart of that, and that their expertise was considered completely on par to any of the professionals that sat around that table. So in Langley, they did a number of different events, but it was interesting. These posters, just to let you know sort of our process of learning, they had a number of posters first created because they wanted to start to decrease stigma in the community and in schools. So they had these posters created by an artist and by professionals, and then they piloted them with the youth and parents in the room. who completely vetoed the posters and said they would not reach anybody. They did not feel like they were a good way of decreasing stigma and promoting the message of increased mental health awareness. And so they actually held a poster contest and had the youth redo them, which engaged the community. It got people talking about it. And these posters have now gone not only around the province, but around the country and around the world, including India, in terms of their reach today. So just, I think, a beautiful example, and the youth involved feeling so incredibly proud of that work in terms of what they've been able to contribute and the meaningful difference they've made in their home community. I also know one of the huge highlights for this local action team and a number of our local action teams around the province was making sure to understand that things like mindfulness, grounding, meditation, yoga, exercise, diet and nutrition were also included as part of an important mental health regimen. And in doing that, to sort of legitimize that for doctors with their patients, a number of the different communities actually created prescription pads where a doctor could prescribe time out in nature, or time doing exercise, or time just grounding themselves in mindfulness every day, instead of just prescribing medications for mental health. Okay, go to the next slide. We also had a number, like Christina was saying, you know, what it looks like in one community in terms of prescription pads and posters and community engagement. What works in one community, you know, is completely different than what works in another community. And truly that is part of why the collaborative was so incredibly successful. That bottom group of youth was a group of really at-risk youth from the Indigenous community, not very far away from our inner city. It was less than a 2-hour drive, and most of those youth on those paddleboards in the ocean that day had never actually seen or touched or connected with the ocean ever before. And that day they were able to pull together through a series of photographs to be able to show pictorially what they wanted to see in their community to increase access. And a lot of it was about youth-friendly activities that were fun and engaging and novel experiences like they had that day to be able to actually engage the Indigenous community in mental health services when they weren't being served very well. Go to the next one. We also had a number of poetry nights, comedy stand-ups, films that were made. And the wonderful thing about the collaborative is we did download everything onto a common website. People had access to templates, posters. They could take, you know, the ideas and concepts, they can cut and paste, they could put their own logos on, because we had really an all-share value that we held in the collaborative, that nobody owned intellectual or property rights, that we really shared everything with one another. We shared our successes, and we actually shared our failures, like I talked about with the posters. We had substance use awareness events that were put on in collaboration with our local RCMP, local book clubs that were initiated. In White Rock, Surrey, we actually had a newspaper column where we had youth, physicians, and community members, including parents, writing about one common topic for that particular column for that week, that continued to run as a regular column in their local paper to increase awareness about mental health services and make it easier for youth and families to actually get through the doors and be able to access services. Poetry flow events. We also held celebrations. One of the things that we really heard about from a number of our rural and remote communities, our Indigenous communities, was that gatherings tended to be happening over funerals and sad events. And in order to increase access to health and wellness in those communities, they needed to do more celebrations, soccer games, and feasts. So they did ceremonies and celebrations that honored youth and families and brought the community together in a lot more positive way. We also, in the Frasers, had regional events where we had large numbers of youth come from all over to gather in different communities. So that was completely youth-led and youth-facilitated. So youth established the agenda, sent out the invites, organized the food for that night, and actually even were the entire speakers for the day and group facilitators. So the only adults that really participated in those days were adults that were crisis support staff to do some clinical support if needed, but the youth completely ran and organized those events and activities themselves, so they could get youth from all over that entire region working on those different initiatives for the collaborative to actually share what was working in their communities and be able to borrow ideas and support one another with what they could be doing in their home communities. We'll do the next slide. So what did the communities teach us? This is a huge one. because when we heard about those two underpinning goals of the collaborative, to increase access and to have youth and families at the center of it, you know, a lot of families were telling us that what they needed wasn't just more access to specifically designed services, but we needed to actually identify what are the root causes that are actually causing a lot of the mental unwellness and substance use in our communities. And so really, I think a resounding effect from around the entire province of our 64 communities was that we needed to look at early adversity and childhood trauma, and to be able to address some of those underpinnings underneath what we see in terms of mental health and substance use presentation. You know, things like, I think about our Williams Lake community, who says, you know, DBT is wonderful, and could we use more DBT clinicians? Absolutely, that would be great. But when our families are hungry and we don't have those first, you know, those social determinants of health needs met first, then really how can we support a community on its route to wellness without addressing those social determinants? So really, I think one of the big legacy items in terms of the collaborative was looking at that impact of early adversity and how we can address that. And then how do we bring trauma-informed practice into and across every sector? So that is, how do we encourage the police to be coming at the way they approach and support our families through a trauma-informed lens, corrections, our education and school setting, you know, and our mental health and substance use services themselves, so that they're able to actually adopt and truly integrate, you know, what we're leading towards in BC, which is creating self-healing communities. And that's not just engaging, you know, our professional institutions and organizations that are serving youth and families with substance use and mental health issues, but it's actually engaging, you know, our local community businesses, and how do we make those environments more trauma-informed and more engaged, so that we're actually supporting our communities overall. Can you switch it for me? So a big piece of what led us into this this amazing sort of, it was a summit of work. So we called it our ACES Summit at BC and beyond. So November 14th to 15th, as our collaborative was really wrapping up, we ended up having 620 registrants, the majority from BC, but we also had Alberta, Saskatchewan, Ontario, California, and Florida come and attend our summit, which was very much like our learning session that Christina was describing earlier. So where we would encourage participation from across the province to come and learn and share together about what was happening in British Columbia regarding reducing adverse childhood experiences or childhood trauma and adversity, and be able to promote resilience within communities. And I think we actually allowed Nikita can correct me on this, but we allowed 620, and we actually have, I think, a couple hundred left on the wait list who are not able to get in the doors because it was so incredibly popular. And it really showcased some of the amazing work that was happening in BC and beyond, and with really strong Indigenous focus throughout the 2 days in terms of what we need to do to be better promoting trauma-informed practice in our province. So today, several of the local action teams are still actually looking at local solutions to doing this trauma-informed work. I think it's really exciting. We actually have an event coming up on Tuesday. So at the Surrey Art Gallery, we have youth that have lived experience of mental health and substance use issues, who are in dance teams, who sing, who are doing visual arts like sculpture and painting, talk about some of their struggles with trauma and adversity and how they've overcome them, and how they found resilience and healing through some of these areas of mastery and skill like the arts. So the Art Gallery is helping co-sponsor that with one of our local action teams who's continued on to this day to be able to help promote and support this work. And it's also showcasing a film screening that looks and highlights the work of offsetting ACEs, and it's called Broken Places. So it's just one example of how so many of our local action teams are continuing to actually do this work, and either with no financial support, with little financial support, or where they've actually been able to cultivate and find their own funding now that the funding has ended. So they've been able to go through finding grants and philanthropy to be able to continue to fund these amazing initiatives all on their own. So one of the communities that I love to highlight, I think, is Mission, because it came from a place of such brokenness. When I first started working with the Mission Local Action Team, they told me that the biggest barrier to accessing services in that community was stigma. That everybody, it was a small community, everybody knows everybody. Our mental health services for young people are located in the same building that you have child protection services. And so some of the challenges and barriers to be able to access that for people was really, really challenging. And so they said, you know, holding a community event here, no one's going to come out. We're not going to see anybody show up to a community event in Mission. And then the city really started taking notice, because on social media, the city started noticing death threats to some of their most vulnerable people in their community, to their homeless, to their addicted, to their Indigenous people who are on the streets. People were threatening to set them on fire and do horrible things. And the city stepped in at that point with a wonderful city planner who had a master's degree in counseling and who had heard of the self-healing community model, and basically took someone from each sector, someone from education, someone from the municipality, someone from the child and youth mental health team, someone representing child protection, to a conference in Walla Walla, Washington called Beyond Paper Tigers, where they could look at how they were going to be able to transform Mission into a self-healing community and increase the community's understanding of the neuroscience of trauma, so that we could really be promoting more compassion within the community. And they did a number of different pieces of work that led to this, but I have to tell you, probably one of the highlights was a film screening where they had over 700 people in this small community come out to watch this film screening, and to be able to hear a panel discussion after about what we need to do to address adversity and how the impact is truly on the brain, and not a choice that a person decides to make, but definitely something that as a community we can support change around. And please feel free to ask questions, and I know we have some time at the end. The White Rock South Surrey Local Action Team, I think one of the most interesting legacy items from them, they're continuing to do ACE's work, and they've actually even passed off a branch of it to parents and youth in the local community to be able to take that on all themselves. They're continuing to train physicians and have professional training events for the community and for the professionals that deliver services to kids with mental health and substance use issues, so that their community can be truly, they would like to see themselves and be able to call themselves a self-healing community. They have a triage team in the White Rock South Surrey area that supports the entire Surrey School District at both the elementary and the secondary level, where they have a psychiatrist, a family doctor, a child protection manager, a child and youth mental health team leader, and district support from the school district in terms of the counseling support and behavior management, to be able to come together with our most vulnerable, most at-risk kids who are either no longer attending school whatsoever, or who are attending school, but they're actually facing risk of suspension. And they come together to pull strings, move kids to the front of wait lists, and do what they can to emergency and crisis plan. So instead of a disciplinary strategy where we actually just move this child to another school, or we expel or suspend, that we're actually wrapping around that child with support and making sure that they can access services in a timely manner. So I mentioned this one. There's been so many different public events. I know for Bell Let's Talk Day, they had over 500 people at the Surrey Art Gallery looking at the neuroscience of trauma, and this was their poster. And they have, I think I've mentioned them, so I'll pass them since our time is dwindling. So we have so many other partners that have focused on ACEs since the formal end of the collaborative. We can keep rolling through, but I think some of the most interesting really is that we have had commitment or support, again, from Doctors of BC to support 200 of our physicians who've been involved in the collaborative, with 3 different working groups that form a community of practice. So these physicians get together for regular meetings that are done by TCON, so they can engage everyone in the province. And the 3 working groups look specifically at addressing adverse childhood experiences, engaging with government and government relations, and then networking and supporting one another to do this work so that they're able to do it well and have a team of support around them. Primary care has had so much attention and so many wonderful trainings around the province, looking at how to increase compassionate care support communication strategies and validation with patients who've experienced trauma, and really trying to shift the conversation that doctors are having with their patients from what is wrong with you to what have you experienced in your lifetime that might be impacting you now. It's been amazing to see how many different trainings we've had, and I think the next slide will show us where we're heading in our, or maybe not. So I'll talk at the end, but we're looking at a guideline in BC to help support physicians, and also 2 specific modules of curriculum development to help support physicians around the province be able to have access to this training because it's been so popular. All right, ITC Corrections. So amazing that they've also expanded awareness of the principles of trauma-informed practice and explored ways to embed the practice into the work. They've actually established a team for BC Corrections, and they're working on policy development and practice implementation at this time, including supporting some of the schools. And I know they have a connection with some of the school districts to actually be writing, supporting healthy relationships programs right into the school curriculum and after-school programming. In Indigenous communities, we're seeing more and more the interest and appetite for understanding the neuroscience of trauma, but also the neuroscience of Indigenous healing, because in Bruce Perry's work, we see so much that rhythmic healing practices really truly are healing the brain and helping people recover from traumatic experiences. And so much of this knowledge is ancient Indigenous wisdom that we've known for a very long time, with drumming, rowing, smudging, that these are the types of things that are actually healing people's brains that are recovering from traumatic experiences, and tapping into how to engage with those cultural practices that support that kind of healing within Indigenous communities. So across those other multiple systems, we have a Provincial Perinatal Services BC pilot project looking at implementing the ACEs questionnaire right now into perinatal care services. So far, the initial data that's come back has been very well received. They're saying that they can ask their patients about early adversity and do that in a meaningful way that actually makes a difference in providing better patient care. We're looking at schools and how they're implementing training and education and supporting their most vulnerable students better. Policing has also been an amazing area. Domestic violence units and police departments interested in how they can actually be more trauma-informed and supporting families where they're presenting to homes multiple times for mental health or substance use calls, and how to be able to support those families better, where they have a better experience with the system and feel more supported than adversarial. Dentistry has been an interesting one. We've had a few different trainings now with British Columbia and Alberta, developing trauma-informed dental practices to be able to help support dentists and dental hygienists in offering services that reach their most vulnerable patients and those with substance use and trauma history, mental health history as well. Pediatric surgery at BC Children's Hospital has actually just completed a piece of research at looking at how they addressed and asked questions about early adversity for kids undergoing pediatric surgery. And again, they've had really positive results in terms of it being a meaningful part of offering better care to their patients. So growing and growing day by day. It's been amazing to see the legacy of what's happened in our province and all these different communities doing such fantastic pieces of work. Again, just highlighting the impact it's had for some of the youth. Like, I can't tell you, I have lists and lists, you guys, of the youth that are doing amazing things that really started in our provincial collaborative, right? Some of our most at-risk youth who are really struggling with their mental health. We have one that's going off to present in at the Canadian Medical Association conference in Toronto as a youth presenter. I'm so proud of her. We have one who's working in a fantastic wellness position for the First Nations Health Authority, who started as a youth with lived experience, passing notes to me back and forth at a table. We have a young man who's completed graduate level work in geology and is traveling the world and writing a blog and doing incredible things. So, and then we have youth and families that have actually been hired by our health authority to provide their expertise as young people and parents with lived experience in our inpatient psychiatric units for young people to help support other parents and help support other youth right from inpatient settings in the hospital. So I can't tell you just the legacy of what's happened in our province and the opportunities for our families and youth to be engaged and find their way of wellness and healing through making meaning of their experiences and offering something back has just been incredible. And I think I'll end there so we can have questions.
Yeah, thanks, Jennifer. So we'll open it up for questions, and I will also say that there are a few links that I was supposed to send to Caroline earlier, so I apologize. But folks can find out more about some of the resources that were developed and some of the different focus of the collaborative here if they want to afterwards. But with that, I will open up for a few questions.
Awesome. So I think that people may still be gathering their thoughts. Such a rich presentation you guys presented today, and I really want to thank you for sharing it with us. I think for me, I think what really shines through is your passion and your pride in what you're able to accomplish. And so I really want to thank you for sharing that, and also, you know, for sharing some very tangible lessons for those of us who are thinking about these kinds of opportunities in our own province here. So thanks for that. Just in the interest of time, I'm just going to run through a couple of our final slides here, and then we'll come back to the chat and see if we've got some questions coming through. Oh, and just a note that Chelsea will pop in the presenters' contact information into the chat as well, just so if there are some follow-up questions, we can get those sent off to you guys through email. So just a note that QI Power Hour here, we've upped our game, and so we have a highly coveted gift that all of our speakers receive, which are these I Heart QI socks. So a note to everybody out on the line today that if you'd like to get your hands on a pair of these socks, we also invite you to become a QI Power Hour speaker. And if you have a topic that you think our community of learners would be interested in, we would love to hear from you. So visit the link that Chelsea just shared out in the chat, and you can pitch us your idea for a topic. And I just quickly want to take a minute to note our next month's session, where we're going to welcome Stephanie Roy McCallum, the Chief Storm Rider with the Courageous Leadership Project, for a session entitled Bravely Leading Challenging Conversations. Change is hard, and even when it brings something better, adapting to and working with change can feel scary, uncertain, and uncomfortable. And the foundation of making any change initiative work in the long term is our ability to talk through the issues, concerns, emotions, and possibilities together. When we have brave, honest conversations, we find solutions to the problems that we face. But the challenge is that no one is born knowing how to have these kinds of conversations, and it takes brave leadership to create that space to talk together in new ways. So we invite you to register for that upcoming session, and we've provided the link to you in the chat. So let's turn back to the chat and just see if we've had some questions coming through. I see at least one that's come through from Brad, asking about the Prevention Institute, who offered a framework in February of 2016, which brought the concept of community adverse experience out of it. A bit of a twist on ACEs. Just wondering about similarities to your work and your experience.
Jennifer, I don't know if you're able to comment on how that might correlate to some of we did. No, Brad, that's not something that I personally was aware of and was drawn in for part of the work, but I don't know if Jennifer, if you can comment.
No, I'm so sorry. I'm unfamiliar as well.
Awesome. Thanks, Brad. But I think one of the things that it does raise is that there's a lot of work happening in the area of trauma and resilience, which sort of go hand in hand. And I think one of the things that we noticed as part in the last year of the collaborative, which sort of mirrors the beginning of the collaborative, is that there's work that's happening individually with groups across the province, but there's a need to sort of look at how you can bring people together in a cohesive way to move that forward at scale, making sure that we're able to capitalize on what everyone is doing, as opposed to being these little pockets of excellence that don't spread. I think one of the things that we noticed when the collaborative was closing out was that one of the reasons we talk so much about ACEs now is because the interest and the energy and the enthusiasm that we saw from people when we started talking about looking at adverse childhood experiences and the impact of trauma and supporting resiliency at a community level, not just with any one individual department or with individuals, that energy, enthusiasm, and the willingness to work on it blew us away. And so we knew that this area of work was one that a lot of people wanted to work in and had started work in, and we needed to look at a way to move forward together. And I think that's some of the work that, Jennifer is trying to move forward in BC as we after the collaboratives ended, because that is what we noticed, and we always like to share with others, is that there is an opportunity here that really is just waiting to be grabbed. And I think it would probably be the same regardless of where you are in the province, because I can't imagine that it's just BC where that energy would reside.
Awesome. And just another quick call out to see if there are any final questions from the participants on the line. Not seeing anything coming through, so I think with that, we'll thank everyone for joining us here today, and we wish you all a safe and happy weekend. Looking forward to connecting with you again soon here at QI Power Hour. Thanks, everyone.
Thank you.
Thank you.
Bye-bye.